Did you know that one of America's most iconic presidents, Abraham Lincoln, is suspected of having a rare genetic disorder? Welcome to MD in the House. Today, we're talking about Marfan's syndrome. Marfan's syndrome is a connective tissue disorder caused by a defect in the protein fibrillin 1, which is distributed in the dermis, arterial walls, and lung tissue. They manifest an aortic root aneurysm or dissection, ectopia lentis, and Marfanoid habitus. Mutations are generally inherited as autosomal dominant traits. The triad of features of Marfan's syndrome includes skeletal, cardiovascular, and ocular changes. Skeletal changes that include long, thin extremities are frequently associated with loose joints, reduced vision as a result of dislocations of the lenses, ectopia lentis, and aortic aneurysms. Let's take a deep dive. Skeletal effects include patients typically displaying a Marfanoid habitus with tall stature and long limbs, positive wrist sign overlapping of the thumb and fifth finger around the wrist, positive thumb sign, protrusion of the thumb beyond the ulnar aspect of the hand when the fingers are clenched over the thumb in a fist. The fingers and hands are long and slender and have a spider-like appearance called arachnodactyly. Cardiovascular effects include dilation of the root of the aorta and the sinuses of Valsalva, which are characteristic and ominous features of Marfan's that can develop at any age. The rate of dilation is unpredictable, but it can lead to aortic regurgitation, dissection of the aorta, and rupture. Dilation is probably accelerated by stress as well as by pregnancy. Myopia is the most common ocular feature of Marfan's and often presents in early childhood. Ectopia lentis occurs in to 60% of Marfan's. An international panel has developed a series of revised Ghent criteria that are useful in classifying patients. The diagnosis of Marfan's syndrome, according to the International Ghent standard, emphasizes two cardinal features: dilation of the ascending aorta with or without dissection, and ectopia lentis. Other cardiovascular and ocular manifestations and findings in other organ systems, such as the skeleton, dura, skin, and lungs, contribute to a systemic score that guides diagnosis when aortic disease is present, but ectopia lentis is not. Investigations such as an echocardiogram, slit lamp examination are done, and genetic testing can confirm the diagnosis. Genetic counseling before testing is recommended. Also, homocystinuria should be ruled out by amino acid analysis of plasma. Interventions such as beta blockers and the ARB losartan may be useful to retard the rate of aortic root enlargement in young patients with Marfan's syndrome. Ascending thoracic aortic aneurysms of 4 or 5 centimeters should be considered for surgery. Patients should be advised that vascular risks are increased by physical exertion, smoking, stress, and pregnancy. Thank you for listening. For more content like this, be sure to follow.